the Bald Oncologist podcast series, featuring Dr. Malwonder.
Where's your janggut?
Initially I thought of keeping lah, tapi gatal lah. Susah nak maintain ni janggut ni. Sorry lah, lain kali lah, next year.
Second question, kenapa kau panggil botak oncologist?
Okay. Itu soalan yang bagus. Banyak orang tanya saya. You kan kenal I dari dulu kan. Kita kan masa tu belajar kuat. Sebelum masuk master rambut lebat macam ikat tau dengan rambut aku. Lepas tu bila join master belajar sakit hati lah. Lepas tu rambut semua jatuh. Stress gila kat situ. Aku rasa bawah tudung kau pun rambut kau kurang sikit.
But Andy can't hide it.
Yeah, I can't hide it. So I embrace it. Okay.
Right,
so
prostate cancer.
Yes. So back to the question.
Yeah.
I want to talk a little bit about SBRT.
Okay.
So what's your experience in SBRT? Do you do?
Well, I do a few.
Okay.
Not much, I would say. But because, it is a treatment that we use in the early part of prostate cancer. So some patients can have option to go for SBRT instead of surgery. But you are the one who actually went for training. Why do you tell me?
Oh, okay. Yes, so I do a lot of SBRTs. SBRT, like what you mentioned, is for early stage prostate cancer. So we had a surgeon earlier on in the talk show. So he did mention about surgery, open surgery, robotic surgery, and also SBRT. So yeah, SBRT is definitely one of the treatment options for prostate cancer. It is less invasive. I would say probably it's still cheaper than doing a robotic surgery also. And there are a lot of new stuff which we can do with SBRT to reduce the toxicity of radiotherapy. For example, like for SBRT doses, when I first started SBRT, I was just doing SBRT, patient just come, we do the CT SIM, I draw the prostate, and then we shoot the radiotherapy beam.
Okay.
But nowadays, we have tumor localization, tumor movement, and all, we learn more about it. So now we can actually put gold seeds in, right?
So it's more precise?
It's more precise, yes. So the verification process is much more better the moment when you have keyword tracking and we put gold seeds into it. It's actually real gold seeds. So I always tell my patient, tu emas 999 tau. Tapi dia macam kurang dari sebutir nasi lah. And then susah nak cari lah.
He didn't have a very expensive prostate after that.
Yeah, they have a very expensive prostate after that. Because it costs roughly, I think, about 5K or 8K, something like that. Yeah, the gold seed is a bit expensive. And plus the procedure to insert it inside. Okay. And then now we just started doing SBRT with a spacer. So one of the common toxicity with SBRT is the rectal toxicity, where your rectum gets the dose, so you can have prostatitis later on. Okay. So when we put the spacer, we actually separates the prostate and the rectum. So we have a space there. So when we do SBRT, your rectum get a very, very minimal dose.
Yeah, because that's one of the toxicity that a lot of patients actually worry when they go for the normal radiotherapy.
Yeah, correct. It's a long-term toxicity. So all of these actually improve the tumor localization. So our high dose is definitely delivered to the central prostate itself. Okay, and we minimize all the toxicities.
But they don't have to have the treatment for long, right?
No, actually compared to conventional radiotherapy, where I think initially when we first started off in masters, we were doing 35 fractions.
Correct.
7
weeks of
7 weeks of treatment. Then we cut short after some of the latest trial, like CHIP protocol came out. We did mention that we are doing at least about 5 weeks of radiation, about 20 times.
Yeah.
4 weeks, 20 times. Okay. Then now moving forward, we are doing SBRT for just 5 fractions.
Okay, so they'll be done in a week.
In a week plus, because we do it alternate days. Okay. So they just come, lie down, like a CT scan, you do radiotherapy, and then you go back home. Okay, and the treatment roughly takes probably about 10-15 minutes if everything is good. Okay, and now moving further, I think a couple of months ago, I think in ISRO, they did mention that they're doing SBRT with just 2 fractions.
Oh, even better.
Even better. So I think probably later on we might reduce our fractionation because it's a high dose. I think it's definitely good for the prostate cancer patient.
I think it's good because, having cancer is difficult.
Yep.
Having to go through long treatment procedures is also difficult. So having something like this, better outcome.
Yep.
Better tolerance also, and more convenient for patient.
Correct. So talking about long-term treatments, like early phase, we do very short treatment because then they're considered cured already.
Yeah.
But those like long-term treatments, like those advanced prostate cancer patients, okay, like their treatment will go on, carry on for like many months to years, and prostate cancer is a very slow-growing disease. So what was your experience in long-term prostate cancer treatment? How long have you had a patient living with stage 4 disease?
Well, I've got a few that goes beyond a decade.
Wow.
I had a patient who's 15 years now on stage 4 prostate cancer, and he's still looking after his grandchildren, traveling around. So it is unlike most of the cancers when you are diagnosed with advanced cancer, where sort of like their outcome is not very good. But I think for prostate cancer, depending on the biology of the cancer, they can survive very long. And I think most of the treatment is bearable, not so much toxicity.
So what are the latest treatment advancement in prostate cancer?
Okay, so we know prostate cancer is a hormone-driven cancer. So hormone has been the cornerstone of treatment. So I think a lot of patients need to know, even though there's new advancement, hormone still is the cornerstone of the treatment.
Yeah,
and
we need to reduce the testosterone, right?
Correct. And the newer treatments are layered upon that. So sometimes patient can be very well just on hormone, but then you have the newer agent, so you have the novel hormonal agent that you can add on top of it. You can do chemotherapy as well on top of the treatment. And also there's newer things coming up, like all the targeted therapies. You can actually get tested for BRCA1 and 2, and then you can use PARP inhibitors. And all of these treatment generally they are oral therapies.
Correct, and it actually extends your life.
Right.
But one main problem what I have with patients is, right, when they say, doctor, saya sudah ambil injection, kenapa saya mau tambah ubat lagi? Because every time you add on another medicine, comes with a cost.
Right. And also toxicity.
Toxicity also. But they fail to understand that combination of treatment will actually give you a better survival, a better progression-free survival, so that your cancer don't come back. You can live longer with it. So I find that always as a challenge to our patient. Did you encounter the same problem?
Yeah. But then if you look at it as well, you have like a different heterogeneous group of patients. So you will have patients who are really sort of like very laid back and they're okay, they're happy with what they are. And then there will be also people who wants to do stuff, for example, that they want to be able to lead life like normal. So sometimes I feel that motivating patients who are in the second group is easier to navigate having combination of treatment.
Yeah, it's personalized medicine. It depends what the patient wants.
Correct. And also sometimes, even though when we you look at the drug medication and you know that this is the particular dose for that patient, but sometimes to push the patient to actually lure them into another therapy, and I'm just trying to start and see if they are okay, and then they have your faith.
Okay.
So
So Dr. Marfuah, is there anything you'd like to tell to our audience today?
So it's
So grow your respect.
Yeah. So it's a month of basically being more aware of all the male cancers, because I think male, they're very shy of coming forward. They often leave it for too long. So I would say know your body, because sometimes it's not just a particular test. You can do screening, but then it's being aware of the changes of your body. I think that's the main part. And come and get it checked.
So just a question for you. We're already hitting our 4 series soon. Have you done your mammogram and ultrasound?
Two.
Oh, okay. I haven't done my colonoscope yet. I need to go for one.
Walking the talk.
Oh shit. Okay, I must learn food. Okay, so thank you for coming for the show.
Thank you for having me.
The Bald Oncologist podcast series